I'd like to welcome you all. My name is Angie Backey, and I'm the Executive Director for Doctors for America. Uh, Advocacy Grand Rounds series is something that we started back in March, and we're really excited for the opportunity to do this once a month, two times with with the same panel, but just a little different flavor in the evening. And the purpose of the series is to provide our 20,000 physicians, medical students, and other healthcare professionals in our network monthly trainings and courses to support you in your advocacy efforts. It's modeled after clinical grand rounds, familiar to many of you, but with an advocacy spin. Our hope is that it will provide doctors and medical students with an opportunity to connect with others doing advocacy work and find maybe some new things that might be of interest to them. I'm going to launch a poll just so we can see where everyone is coming from tonight. And so if you take a minute and do that poll for me, that would be great. And I would like to encourage everyone to share future Doctors for America events with your friends, colleagues, or like-minded organizations that you might belong to or work with. And we'd also love to hear your suggestions on future topics, speakers that you would like to see in the future. Again, we do these events at both 1 p.m. and 8 p.m. Eastern Time so we can offer options to our members. And how many times have you scheduled something in the middle of the day and it didn't work, but you hope at least this way you could maybe attend later? But we've got you covered regardless because we are recording this and we will send this out to everyone so you are able to listen to a repeat performance. While the content may be the same for each session, again, the Q&A conversation might be a little bit different. And we will be live streaming to Facebook Live, and we'll make a recording, and all of those materials will be available to you. We'll be sending that out sometime tomorrow. A couple of quick ground rules for all of our events. Number one, there is no such thing as a stupid question. And speaking of questions, please remember to use the Q&A feature. We'll address your questions during the second half of our session. And look out for comments in the chat. DFA staff will be sharing helpful links during this session as well. And please be mindful in your questions and comments that every individual is at a different state in their advocacy. So this might be a first step for some and a continuing education opportunity for others. So we welcome each of you from wherever you are in your advocacy journey and encourage patience and good intentions from all of our participants. So I'm going to share the poll quick and we can see where everyone is from. We've got a large contingency tonight from the West showing up. So yay, all of our, hopefully some folks from the West Coast, that's great. A lot of specialists on our call tonight, but a little bit of everyone. So just really glad you're here. And finally, the last question, I support some form of universal health care. So again, like in our session today at noon, 100% of you, because that's why you're here, right? So I'm going to stop talking and I'd like to introduce Dr. Scott Poppen. He's kind of a legend around here in DFA. He's very well known in Utah, where he helped with Medicaid expansion, and he is a former chair of Doctors for America's Board of Directors. And so, Scott, I'm going to hand it to you. Take it away.
Okay, thanks, Ainsley. Yeah, I'm not sure I'm quite a legend, but I'll take the compliment. Yeah, so I'm a retired internist from the Salt Lake City area. So welcome. This is our second session of this. So we had a lot of fun at noon with our great panel. So the nice topic is three pathways to universal healthcare. And we are very grateful to our panelists who did a wonderful job earlier today, whom I'll introduce in just a bit. So since our founding in Doctors for America's founding in 2009, DFA has had a vision of promoting health and improving healthcare in America. But we believe that there are likely many pathways to a new system of financing and delivering healthcare. Today, we're going to explore what we think on our Health for All committee are currently the three most likely pathways. But it's important to note that Doctors for America does not endorse any specific pathway. Instead, we endorse 5 principles. So our 5 principles are universality, which is everybody in and nobody out. Number 2 is health equity, better quality health for everyone. Number 3 is improving population health, which is investing in communities. Number 4 is affordability, less spending on healthcare, more spending on health. And last is adaptability, responsiveness to evolving healthcare needs. Let me introduce our panelists. Briefly, you can find their full bios and when you're registered. So first up is Ed Weisbart, and he'll be speaking about the single payer pathway. So Ed's a family physician in St. Louis, Missouri, or as he corrected me earlier, it's Missouri, okay? And chairs the Missouri chapter of the Physicians for a National Health Program, which is, I think, organization we all know. It's a nonprofit, nonpartisan research and education organization in support of providing an improved form of Medicare for all Americans. So after practicing family medicine for 20 years at Rush Medical Center in Chicago, he moved to St. Louis in 2003 to serve as Chief Medical Officer of Express Scripts until retiring in 2010. So he has lots of experience with the insurance industry. He's been a volunteer assistant professor of clinical medicine at Washington University in St. Louis since 2004 and just recently retired from clinical work. It is a national speaker and published author on the needs of the uninsured. Speaking next on state-based solutions is Bevin McLeod. Bevin is co-founder and president of the Alliance for Healthy Washington. Her work there was instrumental in the formation of Washington State's Universal Healthcare Commission. She's worked with a multitude of diverse stakeholders in Washington State to help pass legislation that increased affordability of the ACA changes, increased access to maternal postpartum care, enhanced health systems and pharmaceutical manufacturers, price transparency, and improved the Indian behavioral health system. Previously, she was the program director for Healthcare for All Washington and comes from a diverse background of work on agricultural and economic development and advocacy on behalf of refugees and immigrant communities. Bevin has recently started a new role as the Director of External Affairs and Community Engagement for the Washington State Department of Natural Resources. And our third speaker, who will be discussing improvements and addition of a public option to the Affordable Care Act is Cedric Dark. So Cedric is an assistant professor in the Henry J. Entob Department of Emergency Medicine at Baylor College of Medicine. He currently is on the board of directors for Doctors for America and is the medical editor-in-chief for the monthly publication ACEP Now. Cedric's policy experience includes work for the United States House of Representatives, the Kaiser Family Foundation, and the Joe Biden campaign. Among his policy interests is the study of health reform at the intersection of international health systems, and he has spoken on this topic nationwide. His media experience is extensive and includes print, radio, and television, and you may have heard him on NPR, seen him on CNN, MSNBC, Fox News, and BBC World News. So we'll let Ed take it away.
Thanks, Scott. And thanks, Angie, and thanks to all of DFA for setting this up and inviting me. I appreciate that. So I come to you tonight with greetings from the dark side of the force. As you heard, I spent many years inside of corporate America as chief medical officer of a few insurance companies. And I did that because I believed firmly that incremental steps reforming the health insurance industry from the inside could solve our crisis in healthcare. That's why I was there. But I learned I was wrong about that, and I am still atoning for that. In my opinion, one of the biggest root problems we have with the healthcare landscape today was actually described by Paul Starr in 1982 as a problem of the social transformation of American medicine. So we were an imperfect but very proud profession for generations that had patients right at the center of healthcare. But over the last many years, we have seen, and in some ways encouraged, medicine to transform into a more market-oriented, commoditized service where physicians now are very frequently employed by and certainly in service to corporate America. This to me is one of the biggest problems that we have, and it's exactly what Medicare for All addresses and repairs. And frankly, in my mind, really only Medicare for All really takes this on. So what is single payer Medicare for All? I'm sure you all are largely familiar with it, but it does two main things that in my mind, first, it improves Medicare, and secondly, it leaves nobody out of healthcare. So improving Medicare means adding in the missing benefits like hearing, vision, dental, abortion rights, long-term care, and other things. It means eliminating the copays and deductibles. And once you've done those two groups of things, there's really no market left for a supplemental policy or Medigap or Medicare Advantage. Those things essentially lose their place in the market, which I think is good. The second thing single payer Medicare for All does is it leaves nobody out. It includes everybody residing in the United States, regardless of their age, their income, their employment, their immigration status. And including everybody, regardless of their income, means that the program would be equitably funded through a progressive tax model and really ending what some would consider today's regressive tax model of insurance premiums. So I support Medicare for All because of three core values that it creates. It creates universal, it's care, it's simple, and it's affordable, which overlaps really well with DFA's core values. In terms of being universal, it means you can change jobs, you can graduate from school, you can retire, you can move even across state lines, and you would reliably have the same insurance your entire life. The same insurance for every income level, race, ethnicity, zip code across the United States. And being universal like this makes the entire system much simpler. Simplicity is really important. A single national plan means that patients can go to virtually any doctor or hospital anywhere without lists or directories for permission or anything of the sort. It means no more needing to shop for insurance on the exchanges and marketplaces. I confess that we owe a big debt of gratitude to the Affordable Care Act for creating those exchanges. They were a major step forward, but it's time to move on from that. Patients desperately want to be able to pick their own physician and hospital, but they're not as dedicated to picking their own insurance company. The only reason people want a choice of insurance companies is because pretty much all of the insurance companies on the market are crummy. So we need to fix that. Simplicity for physicians means we deal with one streamlined, reliable insurer. It means we no longer have to fight to get approvals for our patients. We no longer have to guess at our patient's radiology network or physical therapy suite. We no longer have to optimize our coding and documentation. We no longer have to worry about being sued to pay for the future cost of healthcare because it's rolled in. And then this degree of simplicity is really one of the keys to making healthcare affordable, another core value for DFA. And for individuals, that obviously means no copays, deductibles, or surprise bills. Sorry. But for the national economy, there are now literally dozens of solid studies and hundreds of economists who agree that the savings for Medicare for All are equal to or larger than any new costs. And even the bipartisan Congressional Budget Office recently said that we can afford to do this. So the best road forward for Medicare for All for single payer goes straight through Medicare. And Medicare Well, we could pass Medicare for All by just passing HR 1976, the Medicare for All Act of 2021, just passing it. It has 117 co-sponsors, including a lot of important committee chairs now. This is a new thing for us to have that. It builds on traditional Medicare. It improves traditional Medicare to create the robust national health insurance. But building on traditional Medicare means we must protect Medicare. And you probably noticed Medicare is under dramatic attack today. There are two main frontal attacks on Medicare today: Medicare Advantage and direct contracting entities, a new thing. So Medicare Advantage is the most familiar. It now has literally 40% of Medicare members. And Medicare Advantage puts corporate finances dead center, well ahead of patient interests. Medicare Advantage, unlike traditional Medicare, can impose networks and prior authorizations and the other things that most doctors despise and that patients have chosen against when they chose traditional Medicare. And traditional Medicare is precluded from those kinds of things. But the second frontal assault on Medicare, and the newest one, if you haven't heard about this yet, really important, it's called direct contracting entities, or DCE. That's a new innovation from the Centers for Medicare Innovation. And this new concept, direct contracting entities, are essentially Medicare Advantage-like entities that are designed to capture the 60% of Medicare that's not in Medicare Advantage. So it captures people in traditional Medicare, enabling all of the same barriers to healthcare as Medicare Advantage today does. And it has the potential, within the authority of the Department of Health and Human Services, it has the potential to be rolled out across all of traditional Medicare, turning essentially all of traditional Medicare into a Medicare Advantage-like plan without an act of Congress. That's right on the table for next year if we don't fight it. So the best defense for Medicare for all is to strengthen, the best defense for Medicare is to strengthen it. And that means making traditional Medicare more popular by expanding its benefits in the ways we talked about. But whether or not we increase the benefits in Medicare, we really have to limit or even eliminate all of the outrageous out-of-pocket expenses that are in traditional Medicare, the copays and deductibles. These financial barriers, copays and deductibles, make sense if you think the root problem of healthcare in the United States, of the cost of healthcare, is that we just use too much healthcare. But we hopefully all know on this call that the evidence says that in America, we actually use average or below average healthcare services. This relatively arcane sounding issue, limiting or eliminating out-of-pocket expenses, is actually pivotal to reversing the corporatization of medicine. It's pivotal to fixing the core issue that I outlined. It's these out-of-pocket expenses that drive people from traditional Medicare into Medicare Advantage. So we can learn from Canada. We can learn and do better than Canada. Canada, as you know, started in one province, Saskatchewan, and then expanded province by province. But this gradual province by province adoption entrenched their provincialism. It meant duplicated information systems, duplicated claims processing, and even duplication of basic tools like COVID patient tracking applications, where some provinces haven't even done that. It took Canada decades to fully implement their national health insurance program. And this same provincialism is playing out across the United States. I don't know if you know this, but Arizona didn't adopt Medicaid until 1982, 17 years after Medicaid was passed. Missouri amended the state constitution last year to allow for Medicaid expansion, and we still haven't accomplished it because of our legislature. And let's not even talk about Texas tonight. Fragmentation creates wasteful redundancies, unintended patchworks, and inevitable gaps and inequities. And ultimately, it must be disassembled, which is tricky because nothing lasts longer than a temporary solution. Sounds like I don't believe it, but I really do, that incrementalism has an important role in healthcare reform. I suspect the panel will largely agree that Medicare for All is a good end goal, but we each bring different approaches. My charge to DFA is that we evaluate those incremental steps by whether or not they really advance us towards the goal of a publicly funded and privately delivered universal healthcare system. As my friends at Social Security Works like to say, all means all. Although here in Missouri, we say all y'all means all, but it's really the same thing. So we can do this. Thank you for inviting me.
Okay, thanks, Ed. Bevin, you're up.
Thank you, Scott, and thank you, Ed. And, I think you kind of shot me into the line here with your remarks on Saskatchewan from our earlier comments. So just a little bit of overall picture for everyone. I just want to put the caveat on the table that I truly believe that a national Medicare for all system is definitely something that is where we should go, right? I mean, I think that the data are out. I think that study after study have shown that that is the most cost effective, it's the most moral, it's the most sustainable, et cetera. I will say that in the meantime, there are states like Washington State, California, Oregon, New Mexico, Colorado, New York, New Jersey, and many others who are ready to innovate at the state level if we can't quite get there at the congressional level yet. So that's where we sit. Alliance for a Healthy Washington has become a leader here in Washington State in pushing for a state-based approach to, as Ed put it, doing this at a provincial level or a state level, which is one of the opportunities that we have in the United States. We each have a state constitution, and states can move and innovate at different levels if that's how we feel we need to move forward. We've seen a lot throughout our nation's history that overarching changes that we now consider a status quo actually did start at the state level. I think that healthcare could be that. And so that is what we are aiming to do in Washington State, while also supporting, of course, our own Congress members' bill for Medicare for all at the congressional level. So a little bit of history. In 2018, we helped write and then pass a fully funded work group at our state level that put together all the stakeholders that we could possibly think of to come to the table and think through all of the issues and look at the economics behind 3 different models of achieving universal healthcare at the state level. So model A that we looked at and had economic actuaries do analyses on these, model A was a single payer system, as Ed articulated, kind of a state version of a Medicare for all. And that would be like a state benefit package defined by the state and then administered by the state. So publicly funded, privately delivered, single payer system. Model B, exactly the same, except that the administration of it would go through a third party. So let's say a contracted third party that already had the infrastructure for administering claims. And then the third option was a kind of patchwork fill in the gap option and saying, defining where the populations are in the state that don't have coverage, how we could expand programs to those populations, and what those proposals might cost the state. So in all, the actuaries did their analyses, and I think as no shock to anybody here, the conclusion was that a Model A would save the state the most money, of course. At year 1, approximately $2.5 billion, and that's with the implementation costs. And then subsequently, annually, a statewide savings of approximately $5 billion a year, statewide in Washington State. Some might say that's a slightly conservative number. I think there have been some other studies that have said there's even more savings to be had. We didn't have the resources at the time to allocate those savings to really get into the weeds on where those savings would go, how much of those go to individual businesses, large business, small business, families, local government, et cetera. But we do know that annually $5 billion a year savings is real money. So where could that be reinvested across the state? So from there, we were able to draft the first in the nation permanent universal healthcare commission that was passed during this COVID, this last legislative session, all remote session, and which has a mandate of creating and financing a unified financing system for a state-based universal healthcare system here in Washington State. It also mandates that our healthcare authority begin the application process of federal waivers. And I think for those of you who are not familiar with the waivers in the ACA, maybe that's a Q&A we can talk about later in the discussion. But as it is now, that is a very complicated system for states to apply for waivers and receive those federal waivers. And for a state like Washington that has an incredibly regressive tax system, it's imperative that we have access to those federal dollars and to be able to fund a fully universal single payer system at the state level. So that's what we were able to get accomplished this last year. We are also supporting Representative Ro Khanna's State-Based Universal Healthcare Act that was reintroduced this year. Originally in 2018, Congressmember Pramila Jayapal authored that bill, and which would allow states to file jointly for these waivers, as well as simplifying the waiver application process. So in essence, it is amending the ACA and making that application process easier for states that are ready to innovate. So we are happy to be working with and beginning discussions with states like California and Oregon to talk about what maybe a West Coast system could look like, what a regional system could look like. We know that the larger the risk pool, so all of us, the larger number of covered individuals, the lower the cost per person to actually, make that care available. And so if we could get a full regional system, I think that would be fantastic, keeping in mind, of course, that we would love to have a national healthcare program. So that is the state-based approach that we are currently looking at and that we are supporting, keeping in mind that we are also supporting national efforts. So I welcome questions and I look forward to having this conversation again and to hearing all of your questions as well. Thank you.
Okay, thanks, Bevin. Cedric, you are up.
Thanks, Scott. So I wanted to talk to you guys about what we could do using the ACA as a framework to deliver universal care. And one of the places where I first heard this was from Sherry Gleed at DFA's National Leadership Conference back in August. And everything I knew about health economics, I learned from Sherry Gleed back in my days doing my MPH there. So, we talked about Medicare for all. We talked about doing a more federalist type of approach. So it's whether it's single payer or 50 payer, how else could we move forward? Well, first of all, let's look at the political landscape. So Medicare for all polls pretty well if you're looking at it from the standpoint of Democrats. 8 out of 10 Democrats support Medicare for all. But when we talk about Republicans, it's 3 out of 4 in opposition to it. And when you're talking about independents, there is still favorability there, about 58%. But the trick is this: we have to get enough votes in the House, enough votes in the Senate, and a president to sign it to make that happen. And so this is where we could use the ACA as a framework to expand coverage. And if you're crazy enough, maybe you could even do something where we could get universal coverage using the ACA as a framework. So let me try to explain that as a route to deliver care. And one of the things that, if you've never read this book by T.R. Reid, it's called The Healing of America. I recommend you read it because it discusses what happens in different countries and how they approach things. So some places do exactly a Medicare for all style thing, Canada for one, which is essentially a national health insurance program where all the financing pools in to the federal government and gets distributed out for the delivery of care in the private sector. Other countries have like a national health system, like in England, or quite frankly, in the place where I work, which is a county hospital. Money flows into the system. The system essentially hires the doctors, owns the facilities, and everything is controlled by the state at that point. In the sense of, if you wanted to use the term socialized medicine, that's socialized medicine in a heartbeat right there. But then again, there's other countries out there. Germany, for instance, is one that uses what's called a compulsory system, where people are made to go get insurance, but that insurance is private. And everyone is still covered, but the delivery or the financing of it and the delivery is more privatized than what it would be even under a system like single payer. So where did all this start? It started in the 1800s with Otto von Bismarck in Germany. And the system that he set up was something that actually was mentioned or noticed in the United States by Theodore Roosevelt in 1912 when he ran under the Progressive Party for president. He said we should look at what Germany is doing to make sure that people that get sick in the workplace aren't just thrown on the trash heap of society, but are able to have insurance, recover, and return to the workforce. Fast forward many, many decades, and we get to the Heritage Foundation and a guy named Stuart Butler, who essentially wrote a manifesto talking about how we could achieve this type of healthcare system in the United States, where essentially what Stuart Butler said was that there are a whole lot of people that are uninsured, some of which are just, freewheeling, freeloading on the healthcare system because they don't pay in any reasonable way, but they may have a heart attack or be in a car wreck and therefore use the healthcare system. So what he came up with was this idea of first requiring that every family had to have insurance, and that was sort of a personal responsibility provision. But then realizing that not everybody has the same financial resources, coming up with a system of subsidies where you could make sure that people that are lower income or more middle class had some money to help pay for private coverage. That is exactly what Newt Gingrich took in the 1990s to portray as an alternative to the Clinton health plan. And so the Republicans embraced that kind of thing then. And then in 2006, when Mitt Romney was governor of Massachusetts, it actually got implemented. What people now call Romney Care essentially decided to require everyone buy insurance. If you were low income, you might qualify for Medicaid. If you were between, I believe, 100 and 300% of the federal poverty level, you got subsidies for it. And then that became the test case for what turned into the Affordable Care Act. So in 2010, when Obama signed that, we essentially nationalized Romney Care from Massachusetts and created this structure for the rest of the country to be able to use. And we know that it's worked in Massachusetts. The uninsured rate's gone down from 6% down to about 2% now. So where do we stand at this point in time? We stand in a place where there's still about 12 states that are in opposition to expanding Medicaid. I live in one of them. I know Ed didn't want to talk about Texas, but I have to call us out here in Texas because we don't have Medicaid expansion here, and people are caught in what's called a Medicaid gap, not only here in Texas, but in places like Wyoming, South Dakota, Kansas, Wisconsin, and pretty much the rest of the South. So what do we do for low-income people in those situations while we wait for Medicare to be expanded to everybody? Well, one of the things that's going through right now and being discussed both on the House and the Senate is fixing the Medicaid gap by using something called the public option, and specifically a Medicaid public option. What it would do is give funding and subsidies to people that are below 100% of the federal poverty level so that they could buy private plans in the federal facilitated marketplace and have insurance. And the nice thing about that is you don't have to worry about a term called churning as people move up the income scale. So let's say you're making minimum wage, you qualify for Medicaid, perhaps, but then you get a bump in terms of your salary. Now you have to switch over to a different type of plan. With something like this, using the ACA to help cover people with private plans in the marketplace, even if they're below 100% of the federal poverty level, you're able to have a system where people can go from low income to middle income on the same type of insurance scheme. So that's one way that you could do that. And part of the work that I was doing with the Biden administration was offering some suggestions, or the Biden campaign rather, was offering some suggestions as how they might be able to implement that. Now, you could also see this happening as a public option for people currently in the marketplace in competition with current private insurance plans as well. And that's another thing that's happening. But if you want to go a little bit nuts about it, you could even consider long-term a situation where you actually make our federally funded programs, things like Medicare and Medicaid, and use them in the same context where instead of people getting traditional Medicare, they would use the federal marketplace to purchase a Medicare Advantage type of plan through the marketplaces, but with a 100% subsidy. So that's something that could be considered as well, and something which maybe our friends on the other side of the aisle, if they remember that the idea was theirs in the first place, they might want to return to. Who knows? Overall, though, the point of it is this: if we're talking about using the ACA either as a public option or as a way to fill that Medicaid gap, we have to talk about giving Americans a new choice and an option that's similar to Medicare, something that covers people without copayments. There's a strong push to have options that don't have deductibles, making sure that all of the essential health benefits are included, including things like contraception and a woman's right to choose. And then making sure that if we are doing this as well, that Health and Human Services and the Medicare program has the ability to negotiate drug prices, which it's very difficult for it to do right now, because that will help lower the cost of care ultimately. So thanks, Scott, and I'll give it back to you so we can get into the Q&A.
Okay, thanks. All right, so we'll throw some questions out here. We did this at noontime. We had a lot of fun with it. We got some spirited debate. So Ed, I'm going to start out with you. So yeah, I share your skepticism about the insurance industry, particularly the private insurance industry. I'm a progressive doc like you. However, May 1st of next year, I'm going to be on Medicare. And so I'm doing my research. These Medicare Advantage plans are amazing. Basically, I send they take a premium out of my Social Security. And then if I have to, might be an additional premium. Sometimes they're $0. Sometimes they're $40 a month. I get a gym membership. I can get dental benefit. I can get vision benefit. And all my buddies are on these things. They love them. So, and they're as you pointed out, they're more popular than ever. They actually thought they were going to die when the ACA came in because they used some of that Medicare Advantage money to pay for it. But they're as popular as sliced bread. You know, tell me so what's your response to that, and how can we possibly, and you know that if you start trying to attacking Medicare for all, the insurance companies will come out and they'll just reinforce all the good feelings that seniors have about it. How do you overcome that?
This is a really big deal. And I went through this for myself not that long ago. And what we know about Medicare Advantage is that it's really attractive if you're healthy, and it's really troublesome if you're sick. So when you're on a fixed income and you're looking at getting a Medigap policy, which you need if you have traditional Medicare, traditional Medicare has copays and deductibles, and you can go bankrupt if you don't have coverage for that. So most people on traditional Medicare also purchase a Medigap policy. I spend $150 a month for mine and another $25 for a drug benefit. So I spend $175 a month. Whereas in Missouri, I could have joined Medicare Advantage for free. I didn't join Medicare Advantage because Medicare Advantage plans tell you which doctors and hospitals you can go to. They've got narrow networks. If you're in Utah, but you need to go to Boston for your healthcare because you've got some particular problem, you probably can't do that with Medicare Advantage. They're good when you're well. When you're sick, they're not so good. And the real trap is that a lot of people on the fixed incomes think, well, I have traditional Medicare. I'll save the money for a few years because I'm not sick. And when I get sick, I'll leave Medicare Advantage. I'll go back to traditional Medicare and I'll buy a Medigap policy then. And what they don't know is that that's a trap, because the Medigap policies are only required guaranteed issue and community rating. Those protections from the Affordable Care Act, the Medigap policies only have to give you a policy, sell you a policy the first 6 to 12 months that you're on Medicare. If you go more than 6 to 12 months on Medicare and you're in Medicare Advantage, you may not be able to get out. And what we know is that it's cheaper short term. There's a much smaller premium, but there's a $7,000 or $8,000 cap on how much your out-of-pocket expenses in Medicare Advantage can go. And there isn't such a cap on traditional Medicare, because if you buy a Medigap, you don't need to have a cap. You don't have any out-of-pocket expenses. So the whammo is, if you get sick, Medicare Advantage is going to be a real problem for you potentially. And why do you want health insurance? It's because you might get sick.
Okay. Yeah, I think there was a recent study that showed that anybody who develops a chronic illness on Medicare Advantage, they actually 40% of them end up going to traditional Medicare and Medigap. It's just not something that, not affordable if you have a severe illness in Medicare Advantage. Bevin, can you expand and tell us a little bit more about the Rokana bill and what it does to actually lower the barriers in the state level to expand healthcare? This is something that's actually DFA may want to work on after we get through all this reconciliation stuff here next year is, so tell us more about why that's going to be a good thing and why we should work on it.
Great, yeah, thank you. So it's going to be a good thing because what it does is simplifies the waiver application process for states. So currently, there are multiple different federal streaming funds, right? Revenue funds that states receive, right? States receive funds from the federal government for Medicaid, for Medicare. There's what's called an ERISA waiver. And please don't make me, tear apart the acronym, but essentially what it does is it allows self-insured companies to be exempt from any sort of state program that would require them to pay into a state program because they're self-insured, right? So as the only state so far that has ever received an ERISA waiver from the federal government is Hawaii, and that was decades ago. So there is no current modern legal precedent for a state receiving an ERISA waiver. So for a state like Washington State, as an example, that has some of the largest companies on the planet headquartered here, so Amazon, Microsoft, Boeing, these are all self-insured companies. So there's currently no legal roadmap for our Washington State legislature to be able to mandate that those companies pay into the pot for a state program, like a Model A program. So this is really paramount. These three waivers to get Medicaid, Medicare, and an ERISA waiver for a state like Washington, California, Oregon really is paramount in being able to streamline the funding sources to afford a unified financing system so that we don't fund it in a regressive manner. So what Ro Khanna's bill does is it simplifies that application process into a single waiver application. So it'd be a 1335 waiver under section 1332 of the ACA, which is the innovation space, right? So I think one of the key pieces of the ACA that left the door open for states to kind of innovate in terms of like a public option or a universal healthcare system was that specific section. And so what this does is simplify that process. It also allows, legally allows for multiple states to apply jointly. Right, so we could say that Washington, Oregon, and California, as an example, are ready. Let's say all three legislatures have said, well, you know what, we would love to have a West Coast system so that all of the residents of our state, because we know that there's commerce, we know that there's interstate travel, we know that folks, just right here in Washington State live in Vancouver, Washington, and travel to Portland, Oregon for work, right? That's just about an 1.5-hour drive. And so if they're a resident of one state, but they work in the other state, how does that translate if you have a state universal healthcare system? So this could be an answer to that, right? This could be an answer to, cross-border commerce and work. So really it's keeping the fabric of what's intact. I think that Cedric has pointed to, like we have many states that haven't even done Medicaid expansion yet, right? So those states are working on those dollars. But there are states that are ready to take the next step, and Washington is one of them. And so Ro Khanna's bill is instrumental in allowing those federal dollars to come into the door for the states that are ready and willing to make that change. So that's why it's so key and so instrumental. And I have to say, this plays straight into the conservative talking book about states' rights, right? This plays straight into smaller government. This plays straight into saying, like, hey, the residents of California want this, right? Or the residents of Oregon want this. Obviously, their elected officials have made this happen. So let's let them. Why not? I mean, it's the same federal dollars. Let them do with it what they want to do with it, right? So I think it depends on the messaging, and it could be, I think, easily messaged and changed to bring our more conservative, brothers and sisters across the line. I mean, we're not going to get everybody, of course, but I think that, if we have these key conversations, that this is a bill that could move, that at least components of this could move through, let's say, like a reconciliation process.
Yeah, absolutely. Maybe a easier political pathway. Cedric, I have a question for you. This actually came from our session this morning. This is right up your alley, okay? So one of our participants this morning says, there are two objections to universal health care I hear from friends. Number one, rationing of healthcare for consumers. And number two, especially doctors will not be able to make the money that they feel they deserve. So you're our specialty doctor, so address that.
Especially doctors won't be able to make the money they deserve. Yeah, that's one of the huge things that came up when we're talking about either Medicare for all or even a public option, because what are we going to pay? Are we going to pay Medicaid rates? Are we going to pay Medicare rates? Or are we going to pay private insurance rates? If, you know, there's a great study out of Urban Institute several years back that looked at what happens if everybody made Medicare rates for their profession or their specialty. Pretty much emergency medicine, we do fine because we see uninsured people as well as injured people. So we break even. Almost everybody else loses on the order of 10 to 20%. So the primary care docs, you're going to lose about 10% of your salary. The proceduralists, you're going to lose. And I saw there were a lot of specialists on this call. You're going to lose about 20% of your income if you move to Medicare for all and pay at Medicare rates currently the way they are, based on some of the estimates. So that's one aspect of it. Scott, would you mind repeating the first half of that question for me?
One of the criticisms people have about universal health care is that there's going to be rationing.
Okay.
How do you message against that? Yeah.
Well, I mean, we ration right now every day. We just ration by price, you know. So that's the thing. Like, my patients are rationed every single day because they don't have access to any care whatsoever. So they show up with stage 4 cancer, as opposed to making sure everybody has something. And then maybe you have the trade-off of you might have to wait a little bit longer to get your hip fixed. But again, these are decisions that are trade-offs, and people need to understand what that means. It's the same trade-off when we're talking about, do people have copays or deductibles? When you look at current Medicare, the way it is right now, health plan in the private insurance market, the actuarial value for traditional Medicare is about 76%, which is right about what it is for the high deductible health plan I carry for my employer. So, you know, we're making trade-offs of, do you want to spend more on a product so that you can have first dollar coverage, or do you want to spend less on a product by having, you know, some kind of cost sharing thrown in? And the same thing will happen depending on what those levels of coverage are. If we decide zero cost sharing, zero deductibles, zero copays, yes, we're going to spend a little bit more because we're going to have more use of services. Like, that's the Rand health insurance experiment, which came out in the 70s, 80s, and we know that that's a thing. Problem is, we don't know when we introduce cost sharing which aspects of care people are going to get rid of. Are they going to get rid of good things, like things they should get, like managing their blood pressure and screenings, or are they going to get rid of things like MRIs for chronic back pain and back surgeries that we know don't do anything? That's the problem with trying to adjudicate these trade-offs without having a great understanding of what people are going to do.
Okay, Ed, here you go. So
can I, would you mind if I responded to at least one of the things that Cedric said? Because I'm sort of like, do you might I do that?
Actually,
Just very briefly, to throw out that you know, this impact on physician wages is kind of just, in my mind, almost a scare tactic, when none of the bills in the legislature actually propose a fee schedule. So we don't know what that would be like, when most of the economic models assume roughly the same dollar amount to physicians overall, back and forth. When you couple in the fact that physician office expenses would plummet because of so much simpler administration, malpractice would plummet. When you put those things together, to summarize that by scaring physicians at, we're gonna go broke, that's just, no, that's just not an evidence-based way to look at this. The Urban Institute model was one. There are dozens. It all depends on what you assume, and nobody is assuming, or very few people are assuming, we're just going to take the Medicare fee schedule and pop it over to someplace else. This is not in the cards.
Okay.
Sorry.
So no, I was going to actually have you address that. Absolutely. So thinking of my own personal experience of practicing 25 years, where I had about a 65% private insurance in my practice, you know, ranging from excellent to good in reimbursement, about 30% Medicare, which is, you know, lower, way lower than private insurance, and 5% Medicaid. and did hospital work where I got paid nothing. It still sounds like a pay cut to me, but I'm retiring. But let me ask you. Let's say I'm a 30-year-old, like just finishing my family practice residency or pediatrics or internal medicine. I have $200,000 of medical school debt. I want to buy a house. I don't want to buy a mansion. I just want to buy a house that won't blow away in the next 100-year storm, which occur every year now. So what's that look for the younger generation who have a huge debt and are in primary and low paying specialties? Think that's going to work out?
There's no better solution for them. If you talk to, as I do all the time, and talk to people graduating from school and from residency programs, they hate the prospect of going to practice in this crazy system we set up. They are, that within PNHP, the most vibrant, dynamic, pro single payer group we have are the med students, and they're the ones straddled with the debts you're talking about. I got news for you. The old geezers like you and me, Scott, this is not the issue that the younger folks graduating programs largely have, because they know that a program that wouldn't let them repay their finances we're not going to do that. Of course, we want them to be able to have good lives, and all of the models are based on that kind of an assumption.
Okay. Bevin, here's a question that came in last session. Is for you. So when you consider that most states, or a lot of states, my state certainly has a statutory requirement of a balanced budget, what happens in a state-based single payer or a state-based system when you have a catastrophic event like a pandemic? How do states get bailed out there?
Well, how are we all getting bailed out now? Look, I think that if you are, basing your single payer state system on a revenue stream that is sustainable, right? So you're basing it on a progressive taxation system, which there was a question about that. And I will just say super quickly, regressive taxation is basically that people who are on the lower income are paying a higher percentage of their taxable income than the people on the higher end, right? So example in Washington state, is unconstitutional for us to implement an income tax in our state. So how do we fund things? Well, we fund things through property taxes, sales taxes, some people call it sin taxes, luxury taxes, and so on. So example, in Seattle, one of the wealthier cities in the country, the sales tax here is, close to 11.5%, I believe currently. Well, so when you have somebody who's making minimum wage, what percentage of their income are they paying into that sales tax for that same item that Bill Gates walks into the store and pays for, right? So that's called regressive tax. Progressive tax is when you have folks who are in the higher income and progressively paying a larger percentage based on their income. So it's more fair, it's more equitable. So when we say progressive and regressive tax, it really actually has nothing to do with your political standing. It has to do with the way that the tax structure is created. So just wanted to put that out there. So if you have a healthcare system that is self-sustaining, that is based on a progressive revenue stream, right, where you have those revenue sources going in to sustain that healthcare system, which, let's be honest, if you're doing a state-based system, does have federal dollars coming in the door for your Medicaid, Medicare, and so on, then if you have a catastrophic event like we're looking at right now, what's the reality? What we currently have is billions of dollars being funneled into our states for our public health infrastructure that has been woefully underfunded. We had, Washington state just alone, we had to get into a Western state pact with our other governors just to get vaccines, out, just to get testing out. That's not a healthcare system. That is, a broken mosaic of a system. So I don't think, first of all, I think if we had a smoothly operating, sustainable system already in place, we would be saving, first of all, approximately $5 billion a year. So where does that go back? Maybe some of that goes into your rainy day fund, right? But again, if any state, if any country is hit with a pandemic like we're looking at right now, again, the reality is we're going to need the support of the federal government, regardless of what system we have in place.
Right.
That answers that question.
Okay. Okay, so the last question of the evening comes. Ed's going to lead off on this, and so I think that all of us on this call can agree that our current system is dysfunctional. It needs to change. I think that in general we have a vision of where it needs to go. The question is how to get there, and the political process to get there, which it can be extremely difficult. And so, Ed, can you tell us what can PNHP has been working on single payer since 1987. Diligently focusing laser-like on it. What can all of us, even though those of us who are not on the single payer team, or those of us who maybe like Cedric's approach or the state-based approach, what can all us doctors do, all us progressive docs do this year or next year to move the ball forward?
Oh, you just missed my genius comments. I'm sorry. That's important. I mean, we're having this lovely argument of a policy, and it looks like we all disagree, but in actuality, we agree a lot more than we disagree. So, in my mind, the common areas are number one. I doubt most of us would disagree with the idea of that we need to strengthen traditional Medicare, and that means we need to eliminate out-of-pocket costs, or certainly greatly reduce them. And we need to really unite in opposition to this new thing, the direct contracting entity. The second piece is that incrementalism does make sense if it moves us towards Medicare for all, and if it moves us away from corporate medicine. But if it's an end in itself, that's not something that we should go for. And then thirdly, and perhaps most importantly, we need to show up and support each other. We need to show up. We have complex problems that are going to be solved only with not by a single narrow path, but only by a robust suite of solutions. Medicare for all advocates need to respect the legitimacy and importance of the people working on state plan advocacy, and state-based solution advocates should design their solutions so that they can ultimately fit seamlessly into a national Medicare for all solution. We need to show up and support each other.
Evan, do you want to add to that?
Yeah, I mean, I think I'll just echo everything that Ed just said, and I would also just say whatever you can do to highlight, these pieces that actually really significantly move the issue forward. That isn't just a Band-Aid approach. And I won't go into the details, but we did in Washington State pass something that was supposed to be a public option, but has, with subsidies, and has just been a really challenging piece of policy to implement and actually demonstrate that it works. And so I would just be very careful in swift movements in policy decisions that matter for generations. And so anything that we're looking at now to push on and to support, I think really look through the lens of, does this really push us forward, or is it a Band-Aid? And if we're just throwing dollars at it, then maybe we need to reevaluate. But other than that, I just echo what Ed said. And I think that, I would love to get in other spaces with some more conservative ideas, some more conservative folks who I think probably have a lot of misinformation that they're hearing, especially like we just heard, these reimbursement rates and so on. So let's invite each other to other forums, and let's support each other's work as best we can.
Okay, thanks. Cedric, final word. How can we all move together forward?
Final word is look out in your emails from DFA. We're going to be blasting you over the next couple of weeks with some actions that you can take. Number one, expanding Medicare to include dental, vision, and hearing, right? The next thing we need to do, make sure that Medicare can negotiate drug prices. If they can't negotiate drug prices, we aren't going to have the money to pay for all the benefits that we're trying to pay for. And, for states like Texas and the South, what would be really good for us is to find a way to bypass all these legislatures and governors that don't want to actually expand to low-income people. And to do that with some form of public option would be great.
Okay, so everybody should be contacting their senators, no matter what state you live in. Those discussions are going on now in the House Ways and Means Committee, the Senate Finance Committee. They're kind of going on behind closed doors, but call. Best way is to call. I'd say, rather than email or just call them, and if you get hold of their assistant, let them know how you feel about this. We need to improve Medicare right now. Okay, well, that's the conclusion of our grand rounds, and I wanted to thank our panelists, Bevin, Ed, Cedric, did a great job. I had a lot of fun this morning and this afternoon. So this event is available for viewing later on DFA's YouTube channel. They usually pick one of the two, and this is usually the evening one. So this is the one that'll be out there. Please take 2 minutes to complete our survey so we learn more about what went well and what sessions you might want to see in the future. You'll find the survey link in the chat, as well as a follow-up email that you're going to receive tomorrow. Please remember to follow DFA on Twitter, LinkedIn, and Facebook, and to stay up to date with DFA programs, events, and ways to get engaged. Check out our events page on our website. We have a brand new website coming up pretty soon, but check the website for what's going on with DFA. And don't forget to mark your calendar for DFA's next Advocacy Grand Rounds, which is on Thursday, October 9th at 1 p.m. and 8 p.m. Topic to be determined yet. You'll find additional details in our follow-up email. And thank you for attending, and have a wonderful evening.